Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. Mr. Chairman, ladies and gentlemen. Thank you for having me. I'd like to thank the organizing scientific committee for inviting us, the Heart Rhythm Society. And start with my disclosure. I'm an electrophysiologist. This was all over the news just a few months ago. Mortality increases during national cardiology events. Why is that? Interventional cardiologists are attending the meeting. So interesting enough, when you need an electrophysiologist during these meetings, the mortality is not affected. If you present with cardiac arrest or if you present with heart failure and you need an EP, you get an EP. So the take-home message from this controversial slide, be an electrophysiologist, do not attend the meeting, or come to this meeting without an EP. So here is the agenda for my talk. First, I'll introduce you to this technology. I'll show you what it's this device. Then I'll present a case, and we discuss things around the case. Then I should go over some techniques, show you some good images, including transeptal puncture, device deployment, and I will summarize. Watchman, or a left atrial appendage closure device, is an alternative to warfarin. So it's not a replacement to warfarin. This is a very important message. It was designed to be an alternative option. It's not a replacement for warfarin. So here is the case. I have a 66-year-old woman with prior coronary artery disease and stenting 2 years ago. She had non-valvular symptomatic paroxysmal atrial fibrillation. The creatinine is slightly elevated at 160. She complains of palpitation and mild epistaxis. The ECG currently is a sinus rhythm. She's on aspirin, beta blocker, statin, and warfarin, and the INR is stable. So out of my interest, who would offer this patient a closure device for stroke prevention? Can you raise your hand if you think we should discuss this with the patient? She had a stable INR and she presents with palpitation. Would you ever discuss this option with the patient? I guess nobody. Okay. So we should go over before we answer the question, we should go over the CHA-VASc and has-bled. I think it's essential to apply the CHA-VASc and the has-bled score in every single patient you see. The CHA-VASc basically is a 66, so she gets 1. She's a woman, she gets another 1, and she had vascular disease, so she gets a 3rd one. So the CHA-VASc is 3. So she is at a higher risk of a stroke. What's the has-bled score? She's a 66, so she gets 1. She had elevated creatinine, she gets another 1. And she's on a drug which can give you bleeding, aspirin. So the has-bled score is 3. Okay? I think this is an ideal patient to discuss this option, alternative option, because the has-bled score is actually more than 2, okay? I think this discussion should be undertaken in any patient with a has-bled score more than 2. Of course, if the CHA-VASc is more than 1. It was indicated, the left atrial appendage closure device was indicated only if it's too bright, the screen, so I cannot use my Okay. So it was indicated only if warfarin is contraindicated. Was from years ago, from the European guideline. Recently, the FDA changed the wording, so this is very important. It's not only, this closure device is not indicated only for contraindicated patient. Now, as I mentioned in my first slide, it's an option that you should discuss with the patient. It's an alternative option. It's not a replacement again, but it's an option that you should discuss with the patient. So who would need that? Patient, of course, who cannot take warfarin, patient with a high risk of bleeding, 2 or 3, has bled more than 2 or 3, patient who failed warfarin with a stroke despite warfarin, or if the patient wants this option, if it's not convenient. Of course, you should not give it to a patient with a SHA VASC of 0, or a patient with a prosthetic valve, or if she had LA thrombus. So this is the device. It's why Watchman? Why not other devices? Because it's the most studied device so far. It's a nitinol frame device with a fabric cover. It comes in 5 different sizes, 21, 24, 27, 30, 33, which can accommodate almost 90% of all variable shapes of the appendage. This is where you deploy it, in the left atrial appendage at the ostium. So this is just an animation. I hope it works. Oh, luckily it's working. So this shows how you do a transeptal puncture. Usually I do it with an SL1 sheet or SL0. You put a stiff Amplatz guide, guide wire, a 260 over one of the pulmonary vein. You exchange it with a 14 French, very big guide, double curve catheter, a guiding catheter. You push your pigtail catheter for 5 or 6 French or 4 French. I prefer 5 or 6 to give you more stability to your guiding catheter. You advance your pigtail into the left atrial appendage. You advance your 14 French guide as deep as you can. You take your picture. You take your measurement. It's very slow by TEE and by angiography. You look at your chart and you look at your sizing. You pull back, you deploy. Okay, here is the strategies. It could be done under conscious sedation, but GA is preferred because the patient stays quiet with no movement. TE could be done the night before or during the case just to rule out thrombi in the left atrial appendage. It's because it's a contraindication. A transeptal puncture, I'll show you some picture. You have to give heparin to keep the ACT more than 250, 300 preferably. You have to give fluid if the LA pressure is mean LA pressure of less than 10 because the appendage will be underfilled. So you have to give fluid to fill it up to give the proper, to avoid underestimation of the size. You have to use a stiff wire to allow a 14 French to move. And you have to keep the pigtail in all the time and then you deploy. This is a TE guided transeptal puncture. Ideally, the puncture site should be, the transeptal puncture is guided by contrast and also guided by TEE. Ideally, the puncture should be, actually not ideally, you must have a low puncture, mid to low puncture. And try to go into the posterior rather than the anterior. This could be seen clearly by a TEE, a short axis 45 degrees to allow you to tend more away from the aorta, which means posterior, or the bicaval TEE views, which can allow you to go, low, medium. After the transeptal puncture, you change with a stiff wire the usual SL0 sheath to this 14 French sheath. Remember, always keep the pigtail in. Do not remove the pigtail just to avoid perforation of the appendage, which is catastrophic. This live in a box is not a complication, so I'm just showing you a straightforward case with no perforation and no tamponade, no scary things, but that could happen. But it's supposed to be just a routine, well-illustrated, simple case. So this shows an injection of the contrast into the left atrial appendage. The views that I like usually, RAO caudal. You could do any other views, LAO and RAO. It's up to you. The shape is important. You can see that this is a windsock shape. Sometimes it's tricky when it's a chicken or broccoli type appendages. This marker helps you to estimate the size. So this is 21 size device. You can see that this is the almost the os where the appendage meet the left atrium. You can see the flush of contrast here into the LV. So you can see if you deploy this 21 millimeter device, then it should be deployed really at the os. The idea is to avoid any deployment deep into the appendage, leaving some pectinate behind, or avoid also significant protrusion. So this shows the deployment. Sorry, I should go back maybe if I have more time. I think I skipped one. Yeah, so this. Yeah. Yes, okay. Yes, go ahead. So we did the alignment here where we put the two lines together, and after the alignment we just pull back. You see the two marker came back and the tip of the device is protruding. So that's when you should unsheath the assembly and allowing the device to come out. So basically you do not push the device in because the device is already very deep in the appendage. What we do is usually we pull the assembly back rather than pushing the device. It's called unsheathing. So you unsheath the device, allowing it to deploy. This is a contrast after deployment, just to check the ostial location. You can see here is the location. It's most likely at the os. We will check by the TEE. You can see this radio opaque dot, which also indicate the base of the device. So after you deploy, you check your stability by doing a tug test. You pull the handle just to make sure that the device moves as a one piece and it's not coming out. You check your TEE to assure complete sealing and compression of the size. And of course, this is just to show a sealing. Sealing is allowed if it's less than 5 millimeter. This is TEE views. You can see that this is the coronary, the circumflex, sorry. You can see the device is just maybe 1 millimeter proximal to the perpendicular line from the circumflex artery, which is acceptable, very well acceptable. So when you're happy, you have your sealing with no leak, and you have your tug test, and you are happy with the device is not protruding, you just counterclockwise a few times, and this allow it to come out. After that, if it's under GA, you extubate, you give low molecular weight in the evening, start warfarin and aspirin, do your transthoracic echo the next day with the chest x-ray. The chest x-ray is tricky sometimes. It's very hard to see. The first case that I did, I thought it came out but it's very tricky, and it's very small device. Sometimes you cannot find it, but don't be scared because I think it's there most 99% of the time. You have to do over-penetrated X-ray to see it, just anterior to the trachea. This is the protocol. In fact, I believe, not me, not only Fayez believe, but most people across the world believe that maybe it's okay to stop warfarin immediately and just give aspirin and Plavix according to ASAP study. So this is what I do actually. I don't give warfarin. This is the Protect AF protocol. You give warfarin, aspirin, and then you check the TEE at 45 days. If the sealing is good and no thrombus, then you stop warfarin and keep the patient on aspirin and Plavix. Or you could go immediately to aspirin and Plavix for 6 months and do your TEE at 45 days. And if there is no clot and the sealing is good, you can stop. You stop Plavix and continue aspirin indefinitely. The device is supposed to help endothelialization. So at 3 months, you should have a better healing. So this is a live-in-a-box case, so should not show some data, but I thought I should conclude by showing this beautiful one. After 6 months, when you stop your Plavix, you stop your warfarin, look at the impressive reduction in bleeding. 71% relative risk reduction compared to the warfarin arm. So you get a massive reduction in bleeding complication, including cerebral hemorrhage, if you stop your Plavix and warfarin. Having said that, warfarin is an ongoing risk. The risk increases with time. The device is only one time, and you are gone, and you will be good. So why left atrial appendage corroded device and not warfarin? Is just in order to avoid this. Thank you very much.